Hi, good afternoon, 12:30 on a beautiful Thursday. We're happy to be back, Newton-Wellesley Medical Group Lunch and Learn. Today, we're really excited to have Dr. Andy Freiberg to be talking to us about choices for hip and knee arthritis, family questions and answers. Next slide, please. Today's talk is available for a CME code, CME credit, 30 minutes. That's the code. Please text it to SMS code to that number up there. I'll put that in the chat box, DOLRAR, for those of you on the phone. Remember that code is good for up to, I believe 7 days after the talk. Next slide. So we want to tease upcoming Lunch and Learns. We have one more in December, and then we'll take a break through the holiday season and be back at you on January 7th and 14th. Next week, we're going to hear from Dr. Gigi Sheftel about the Echo Lab and some clinical pearls and takeaways. And then we're excited for our first 2 weeks in January, one by Dr. Avner Alifas, one of our ear, nose, and throat docs on staff. I love his title, Wax On, Wax Off. Even Ralph Macchio knew there was more than one reason for earfulness. And then January 14th, Nikki Leung's going to give us a talk on elbow pain. I also want to tease this week's upcoming Grand Rounds Department of Medicine on Wednesday. And that is GI interesting cases. So that should be a good Grand Rounds as well. Next slide. Also, just 2 seconds to talk about this year rounds of wellness grants. I talked about them last week, and I can give you any more information offline, but we did get grants for virtual fitness programs, either through using the Peloton app or the Shipley Fitness Center. We have an inpatient physician wellness project and a physician care concierge project. All of these, we are proud to say that the hospital is now supporting our APPs, that is our nurse practitioners and our physician assistants are also qualified for these programs. Next slide. And here's the Peloton app. And if you do have a Peloton and you ride with them, we are building a community online there using the hashtag NWHstrong. Those of you who know, you can have 6 or 7 hashtags, so you can add it to your Pelo dog hashtag or whatever you have. Next slide. And then here's a quick shout out to the physician care concierge. I actually just used this in my life. We needed someone to regrout our tub. So I sent an email and I got 3 names of local businesses, and Sir Grout a Lot came out and gave us a quote. So pretty cool stuff. Now they won't do the stuff for you, but they can easily set and do some nice research for you. It's a nice service. Really worked well, smooth, all email, very touchless. It was very nice. Next slide. And I'll leave it over to Dr. Freiberg. Thanks so much for coming. And if you want to put your questions in the chat box, he'll leave some time at the end. Thank you.
Jonathan, thank you so much. I hope everybody can hear me fine. Thanks for taking the time during your lunch, 20 minutes, to look at some slides and think a little bit about hip and knee replacement. What I thought I would do is put together a presentation today that would really address some of the common questions you might get from family or friends. I sort of thought about it around the holiday season, and even though we can't be together, people often are asking questions on Zoom about, what type of bearing surface, what type of hip replacement, and what are the things that are relevant for you to know when talking to your patients about the choices that we have as orthopedic surgeons. So that's really what the focus of the talk is today. And I hope we have some questions, just a couple, and we'll have time for that. The important topics that we'll talk about are the diagnosis and some things about diagnosis that are maybe a little bit different than you expect, non-surgical treatments, indications for surgery, and then a fair amount about the different bearing surfaces and surgical approaches and implant options. Because I think that you want to be well versed in this enough to have some conversations with your patients, understand their questions, and try to anticipate some of the things that they're going to have to decide and to work through. I don't know, some of you I know, some of you I don't. I worked as chief of the hip and knee service at Mass General for 20 years. About 10 years ago, we started a combined program, and due to the philanthropy and generosity of Jim and Ellen Kaplan, started the Kaplan Joint Center at Newton-Wellesley, which has really been a long-term collaboration between orthopedic total joint surgeons at Newton-Wellesley and Mass General. And that's where I am now a full-time employee. If you look, we're a coordinated center for the evaluation, diagnosis, really and treatment of hip and knee arthritis. And as a group, we have extensive experience and capability, including something that might be important, which is urgent same-day visits. There's almost always one of us here. Our nurse practitioners are very capable. and any one of us can see an add-on for somebody that you're very concerned about or who needs something addressed on the same day. And so the Kaplan Joint Center on the main campus of Newton-Wellesley is where you'll find me. So let's get right into it. When we think about the diagnosis of hip and knee arthritis, maybe to your surprise, plain X-rays are absolutely the best. And the images that we obtain for hip arthritis or an AP pelvis, which for us is really a chest X-ray, an orthopedic version of the chest X-ray, it gives us a lot of information about what's going on. Let's just look at both hips. And then we get a dedicated AP and a lateral view of the affected side. For knee, we get what we call our standard 4 views, which is a standing AP, a lateral, a 30-degree flexion view so that we can look at the other compartment. I'll show you an example of why that's important. And then a sunrise patella view. And this is really important for us because if we don't have the 4 views, we really can't give people an opinion. And if we don't have a standing AP view, it really underrepresents arthritis. And if you see like the typical sort of trauma series of just an AP and lateral non-weight bearing, we really can't tell somebody how much arthritis they have or give them any advice. So sometimes we have to repeat those films. So if you're evaluating people for osteoarthritis, get the weight bearing AP. And I think what's interesting is that, we see people who come in with an MRI with osteoarthritis, but frankly, the only time we need an MRI is if the films are normal. So we get an MRI to look for a meniscus tear, but I've talked to a number of internal medicine, to primary care physicians who think that they need to get an MRI, particularly of the hip, to show the severity of the disease so that people maybe get addressed sooner or, get treatment sooner. And that we really don't need an MRI for these situations. And sometimes it's actually confusing for us. So this is an example. This is a weight bearing, and you can see it says standing. So that's our way of knowing it. A standing AP and a lateral view, and you can see pretty much bone on bone or, pretty moderate osteoarthritis of the medial compartment of the knee. This is a person who was sent to me for consideration of a partial knee, and we'll talk more about that. But if you look now at the 30-degree flexion view, which we always get, you see a large osteochondral lesion on the medial aspect of the lateral femoral condyle. So this person, despite having a relatively normal patellofemoral joint and mostly isolated medial disease, needs a total knee replacement. And so we always need these 4 views. It's really not as difficult in the hip. In the hip, I think the diagnosis of osteoarthritis is usually more straightforward. There's usually loss of joint space, particularly superiorly, sometimes just medially, osteophyte formation, subchondral sclerosis, which you can see with sort of densification of the bone. Here you see a couple subchondral cysts are actually on both sides of the joint. You see the surface is irregular, it's flattened. And this has actually, and I showed this because this has what we call pseudo subluxation. It's almost as if the hip is dysplastic. It's almost pushing out because the osteophyte's growing, and this makes the hip feel particularly terrible. But plain radiographs for us are the hallmark of diagnosis for osteoarthritis for both hip and knee, not so much MRI. When we think about non-surgical treatments, I think we're all very familiar with physical therapy, weight loss, and joint injection. Physical therapy for us can be useful unless there's really very serious disease. If there's advanced osteoarthritis, for us, physical therapy is more in just strengthening before surgery. And depending on insurance coverage, if somebody has really advanced disease, we want to save that physical therapy for post-op. Weight loss can be important because our hips and our knees are off-center. They see 3 to 4 times our body weight. So small changes in weight can have a huge effect on our hips and our knees. And we'll see people who are heavy, who have early to moderate disease that can get dramatic improvement with a little bit of weight loss. Joint injection is both convenient and controversial. So the things that we can put into your joint are steroid or hyaluronic acid, as we call it, viscosupplementation. The other things that we can do are PRP and stem cells. And I guess what I'll say is that you want to be relatively judicious in what you inject into people's joints, and both for the side effects, and also, whether it works or not. So I'll show you a slide about corticosteroid injection. I do that, for somebody maybe once a year if they have a special event and they have early disease. But multiple steroid injections has been clearly associated with increased risk of infection when we do a joint replacement. So lots of corticosteroid injections are not something that orthopedic surgeons like. Viscosupplementation can be expensive because insurance may not cover it, but there's no increased risk of infection. It's FDA approved for use in the knee, not in the hip, although we will use it off-label sometimes in the hip, but that's also really a hallmark for injection around the knee. And PRP and stem cells, I guess the best way to leave that is that the data on that is that it might be helpful, but for the most part, it's not something that I really believe in, particularly with people who have real osteoarthritis. So a few years ago, my colleagues and I we looked up people who had multiple corticosteroid injections around the hip, and their infection rate went from around 2% up to just over 6%. And so that's in a small series, and this has been reproduced and restudied by other investigators. So we really don't like to do multiple injections around the hip. I'll use it once in a while for diagnosis if I'm not sure if it's back or hip or knee. But as far as therapy goes, it's not something that I routinely do, and not something that every patient should have before they have a hip replacement. When we think about, who you're going to who you're going to recommend to have surgery, these are people that have radiographic bone-on-bone arthritis with limitation of activity. And I mean, not running 10 miles, but have limitation on a daily basis, often sleep disruption in the knee, failed arthroscopic surgery, and the hip osteonecrosis. And I put this picture of a very debilitated person with vascular disease, obesity, in a wheelchair, just to point out that don't keep people delayed from joint replacement so long they become debilitated. Joint replacement is extremely successful, extremely safe, and allows people to go back to virtually all activities of life. And it used to be that we were concerned about infection or wear or failure of joints, and we delayed people many years. And just think about not having people become debilitated and lose activity and not participate in an active lifestyle as we go through the non-operative management protocols. So what type of hip replacement should I have and how long I last? I'm sure that's a question you get. I know it's one that I get. And what this comes down to are the bearing surfaces. There's a variety of different bearing surfaces. Here on the bottom left, you see a polyethylene cup. We use a special polyethylene called Crosslink with a ceramic head. This is a metal liner for a metal on metal, and this is a ceramic on ceramic. Ceramic on ceramics were more popular in the late 90s and early 2000s because it prevented polyethylene wear, but they really went out of favor because of fractures of the devices and because of squeaking. And you could literally hear people walk down the hallway with a squeaking ceramic hip, and that fell out of favor for a lot of us. The other thing that was very popular in the early 2000s were metal on metal hip replacements. And that causes cobalt and chromium ion wear and can cause really serious complications. And metal on metal hip replacements really aren't done anymore. And I think one of the things that I want to point out to you on the top left, you see this device? This is a hip resurfacing device. Hip resurfacing in the United States is always a metal on metal device. And I think it is not the standard of care and should be avoided for the complications and early failure. So metal on metal hip resurfacing, not what you want. And this was very popular and actually done quite a bit in some hospitals here in Boston. And the failure rate and reoperation rate of these patients is quite high. It was touted as something for young active patients. But if you look at survivorship curves, both from individual surgeons and from registries, the 10-year reoperation rate is anywhere between 50 and 70%. And that's because of the metal debris or loosening or fracture of the femoral device. In fact, I think a metal-metal hip resurfacing is almost the only wrong answer in today's world. Some people will look at the registry data and say, look, it works better in young, heavy, active males with good bone. I don't think that it's still indicated in those people. and I certainly wouldn't have one myself. So resurfacing bad, ceramic on ceramic not really done anymore. Ceramic femoral head on highly crossing polyethylene is the standard of care in our community and in the United States. Let's switch over to knee just for a second. One of the things that you'll get asked about in your family, I'm sure, and your clinical practice is, what's a partial knee replacement, a unicondylar knee, and how do I know if I should have a total knee or a partial knee? So when we look at this person, you see, as I'm showing with the pointer, they're bone on bone in the medial compartment of this knee, of the left knee. And the other side looks just fine, and the patellofemoral joint looks pretty darn normal. So the question is, should this person have a partial knee where we just replace half the knee, or should they have a total knee? And that's really an important and controversial sort of situation in joint replacement. So this is one good solution. This is a total knee replacement where we replace the top of the tibia and the distal femur, showing you in a couple of views. And we also usually replace the underside of the kneecap. So that's a total knee. But here's another very good solution. And in fact, this is that person where I just replaced half the knee, doing a unicondylar or partial knee replacement. And this has some advantages and is something that you should discuss with your patients. So why have a partial knee? Frankly, it's a faster and easier recovery with better range of motion. You retain your anterior cruciate ligament and it feels more normal. It's almost always done as an outpatient, and most of us have done these as an outpatient since the early 2000s, and higher patient satisfaction. So in general, if I can do a partial knee replacement, I will. I like doing them, and it's been very durable for patients over decades. The other thing that's kind of interesting, if you look up the data, these patients who have a partial knee replacement have a lower 10-year death rate than total knee patients. And although they have a slightly higher revision rate to a total knee replacement, as a friend of mine said, I'd rather have my knee reoperated on than be dead. And now this might be selection bias, but people who have partial knees tend to do very well. And if they can have one, I think that's really a good option for people. You'll hear terms about conventional surgical approach, old style. You'll hear discussion of minimally invasive surgery and robotic surgery. And I just want to take a couple of minutes to show you what this means and give you some tips. So we really began doing minimally invasive hip surgery in about 2003. And this is a patient of mine that I used with a technique called a 2-incision hip with 2 incisions that were about 3-4 centimeters each. And the idea was to have earlier rehabilitation and function, lower blood loss, et cetera. And what's really morphed over time is we've switched from a 2-incision to a single incision that's smaller with less surgical dissection, better anesthetic techniques, and better pain management. So we can do these as an outpatient or an overnight stay. And I guess, why would anybody care? I mean, I think people don't want to take 3 months off from work or from their life. And our goal has been to make this common operation better. And newer surgical techniques are really better than they used to be. And this is an example of what a minimally invasive surgery looks like. I know it's lunch, so I didn't want to show anything that would freak people out, but it's a smaller incision. Often our instruments have lights so we can see down inside and work through. This is about a 3 or 4 centimeter incision to get done what we need to do. And here we are getting ready to close, and you can see small incisions, less blood loss. Minimally invasive surgery is now the standard of what we do in hip and knee, really across the board. In hip replacement, we talk a lot about different surgical approaches, and I'm sure you've heard about direct anterior, posterior, or anterolateral approach. And this is just how we make the incisions around the hip to dislocate the hip and to get access to bone to put the new parts in. And they're all minimally invasive, but they're a little bit different. And in this short time, what I'll basically summarize is saying that direct anterior, those patients might have better pain relief and recovery in the first 2 weeks, but there have been a lot of studies that show there's no difference at 6 weeks. The thing that we think about direct anterior is they have a slightly higher infection rate and a slightly higher fracture rate of the femur during the surgical procedure compared to other approaches. The posterior approach doesn't have those features, but has about a 1% higher risk of dislocation compared to direct anterior. And so both surgeons and patients and you guys need to weed through and figure out what might be best. But in general, surgeons do one or the other. Anterolateral is a technique that we really only use today for our fracture patients, for our hemiarthroplasties. The risk of that is a slightly higher risk of limp, but it's very, very stable, and the risk of dislocation is as close to zero as you can get. So those are the three different approaches, and I'd be happy to talk about that when we have a couple of minutes. I'll just say that robotics are coming. They're used in some centers around town, and the way we think of robotics is simply a way to help us get our surgical alignment. We're in the process of getting a robot at Newton-Wellesley, one that doesn't require a CT scan preoperatively. And basically, we view this as a very accurate surgical tool that helps us get alignment of the distal femoral cut in the tibia and helps a little bit with balancing. I think one thing to think about is, do orthopedic robots, even matter? And our literature suggests there's perhaps increased accuracy, but so far we haven't had any major studies that show remarkable differences in outcome. There's a lot of patient interest. There is a slightly increased cost per case. And this is something that I personally believe we should approach a little bit cautiously, but also have access to the latest technology when we think it's important, particularly for individual patients. I don't have time to go into detail. I'm sure you've been asked about from patients or family about a painful total joint. Particularly, it's commonly a painful or stiff total knee. And I think when you're doing this in your clinical practice, you want to try to understand what the orthopedic surgeon says in their notes and what their perspective is. And then we and I are always happy to do a consultation for this, or if there's concern for undiagnosed infection or unusual pain. This is very much a specialty exam. This is, to me, a little bit almost like a pediatric cardiac exam. This is something that those of us that do hip and knee replacement full time do, and even general orthopedic surgeons will refer to us for evaluation of a painful total joint. I show you this. This is a great example. This is a person who had pain in the right knee. Their MRI showed a arthritis in the knee, and even though it wasn't bone on bone, they had a total knee, and they didn't do very well. They went on to have a flexion contracture, and this is a total knee. It's not loose. There's no problem. And the guy was sent to me for evaluation. I examined him, and his hip was very stiff on that side. And people can have thigh pain or even knee pain from ipsilateral hip osteoarthritis. So if you see something that's unusual around a total knee, don't forget the hip. And we always get a pelvis x-ray to make sure that we're not confused about knee pathology in the setting of hip arthritis. Just something for you to keep in mind in that patient of yours that has a painful total knee that's just not getting better. So what do we do to evaluate a painful total knee other than physical exam? We don't really get additional imaging, but we will obtain a SED rate and a CRP. Some surgeons like an IL-6, but most of us will do an aspiration of the joint and send it for cell count and what's called synovusure. And synovusure is a proprietary test that looks at alpha defensin, which is made by white blood cells and is shown to be very sensitive and specific for infection around a total joint. And this just shows sort of a little graph of the alpha defensin levels in an aseptic joint in patients that have some metallosis or debris from the joint itself, or those who have infection. And you can see there's pretty good separation in the alpha defensin levels in people who have an infected total joint. And this has stayed true with really high sensitivity and specificity over time. It's really a hallmark of our evaluation of a painful total joint. So what I'll do is leave a couple minutes for questions. Let me summarize by saying, get high quality x-rays, 4 views of the knee. It's okay to try non-surgical treatments. Don't do a lot of corticosteroid injection. It can just lead to trouble. We're available as a consultant anytime. If you need somebody seen the same day, any one of us is happy to see people and just send them on over, and we can be reached at the Kaplan Joint Center. I put my cell phone number up there. I'm very open to calls for questions about evaluation or seeing people, or even questions about the care you're, prescribing for them individually, or for simple questions. And thanks. I think we've got a couple minutes for
Yeah,
some.
thanks. Yeah, thanks. What a great talk. And there's the code again, DOLRAR. I'll put that in the chat box. So there's a question here, Dr. Freiberg. Anything to prevent hip and knee problems is the question, a pretty generic question.
I guess you could be an astronaut, but I don't know. I mean, I think one of the things that's fascinating is I see people who are inactive, who are morbidly obese, who have disease. I see people who are incredibly fit, moderately active, with a heart rate of 45, and just super fit people. I'm not sure we really understand that. I wish we did.
Yeah. I had a question, given the new governor's regulations coming on Friday, and there's been a lot of talk, I know, in at least the primary care literature about the same day hip replacements and sending people home. Where are we at the Joint Center with that program, and what are your thoughts about that in general?
So great question. And as I said, I started doing outpatient joints in 2003, and I both individually and the group, the orthopedic surgeons here, we have a collective good experience in doing outpatient joints. The question is the setting. So you can do outpatient joints in an ASC, or you can do it in a hospital setting. It takes a little bit of planning and a little bit of organization, and we do some things with the anesthetic as far as making it a little bit shorter, and do some other things for pain management. But it's basically the same procedure. There are definitely people who are good candidates and have the support for it and the family that can help them. And then there are people that have too many issues, either social or medical, that are not a good candidate for outpatient. And it's not that hard for us to sort that out. So next week, for instance, I converted I had 3 cases on Wednesday. One got canceled because we had to decrease our elective surgery numbers a little bit, but the other 2 will be outpatient, 1 hip and 1 knee. And that's something that we can accomplish here.
That sounds great. Wonderful. Couple other questions in the box. What is the volume of knee and hip replacement weekly at Newton-Wellesley? I guess if you can ballpark that number.
So I'll say in non-COVID times, I don't know the exact number, but I would say it's probably in the 20 to 30 knee a week, and probably 20 hip or something like that. I mean, this is a busy place for volume for hip and knee replacement. And when we started the combined unit with, when I was at MGH and here, I've been coming here for about 10 years. I think we do a couple thousand joints a year here.
Wow.
I mean, it's a high volume. What's interesting is we've got a very nice approach to handling volume in a personalized way. I have many patients that have had surgery downtown and here, and they like it here. It feels more personal, and it's been a good place.
Just one other question here. It looks like what is the average length of stay for patients who undergo total hips or total knees? I guess it's building off my question I asked previously.
I think if you look over time, if you look sort of over time, and if you look across all patients, so if you include 85-year-old people and 45-year-old people, the average length of stay is probably 1.5 days. If you look today, our length of stay is around 1, because we do some as an outpatient. Most is overnight, and very rarely somebody 2 days. And we just, we don't kick people out. If they need another day of therapy and to make sure that nothing's going on, if they're a little hypotensive, we keep them a little bit. And so, but I'd say it's around 1 day.
And the average guy who has a full-time job, or gal in the 50s who's going to do a total knee, how long can they plan to be out of work, would you say, if it's somewhat of a physical job, if it's not a desk job?
So if it's a physical job, if they're carrying, lifting, and doing those things, I tell them to think about 4 to 6 weeks. depends on how physical it is, because we don't want them to go back and get hurt. And most
Right.
employers don't want somebody to go back and get hurt. So if they're doing heavy construction, they need to be pretty good.
Right.
Um, and 6 weeks I think is pretty reasonable. That's what I tell usually police officers if they're not going, a desk job, they can be back in a week or two comfortably. But if they're running around as a fireman or a police officer, it's usually 6 to 8 weeks, maybe 12 weeks in some people, but it depends on the job.
And then our chair would like to know, he said you talked about bearing surfaces and longevity. Can you talk a little bit about surgical skill, meaning fellowship training and the number of cases per year, essentially, the difference between someone like yourself who's fellowship trained versus an orthopedic surgeon, a general orthopedic surgeon, I think is the question.
So I don't think we have good. I can only tell you what the data shows. So the data shows that uh, uh, fellowship training or not is not as critical as surgical volume, and the number for us um, is something frightening, like 30 cases a year, 20 cases a year. It's low. Probably the largest volume effect has been shown on partial knees. If a surgeon does fewer than 5 partial knees a year, they have a higher complication rate. But I think general orthopedic surgeons can do a good job of hip and knee replacement, but it doesn't worry me. Uh, you know, I think in today's world, most people gravitate towards subspecialty trained people for specialty care, if you will. So, if you're going to go to a cardiologist if you have a bundle branch block, and I'm really winging it here, folks. And so, I'm sure that most primary care physicians can handle decisions about a pacemaker and those things. But when you have a cardiologist, why not let them do that? And even within cardiology, there's specialists for EP. And the same is kind of true for what we do, in that for most people, I think most general orthopedic surgeons, if they're interested in joint replacement, can do a very good job. But for those of us that do anywhere but in the hundreds per year, and that's what we've done for 25 years, it's a little that there may be an advantage to that.
Excellent. Well, we reached our time. Thanks, Dr. Freiberg, for being here. We can invite you back next week to talk to us about the difference between left and right bundle branches if you'd like. Otherwise, we'll see everyone next week. Everyone have a great weekend, and we'll see you. Don't forget about the Wednesday grand rounds, which is GI cases, and also our Monday night staff calls is a good way to stay updated on different programs that are going up around COVID, vaccination, and testing, et cetera. That's at 5 p.m. Thanks, everyone. Have a great weekend. Thanks. Bye.
Thanks, Jonathan.
Okay,
Thanks,
you're welcome.
everybody.
Sure. Bye.